Hello, and welcome to Ethics on Call, the podcast of the Center for Theology and Ethics in Catholic Health. I'm Dan Daly.
And I'm Tom Bushlack.
And today we're going to do things a little bit differently on this episode. We attended the annual conference of the American Society for Bioethics and Humanities, better known as the ASBH. That was in Portland in October. And today we're going to reflect a little bit on some papers that we attended and also interviews that we conducted that you'll get to hear during this episode. So this is kind of a state of the field. Now, this is not at all comprehensive, but what we're trying to do is take the temperature a little bit of what's out there in terms of papers that we thought were interesting, but also just asking people what's a key issue that you're confronting right now, that's confronting you, I suppose. And so that's the kind of the gist of the podcast. It's a little bit different, but I think interesting.
Yeah, so just to give you a little teaser, the three interviews that we have coming are with Michael McCarthy. He's an associate professor and graduate program director for the Healthcare Mission Leadership Program at Loyola University, Chicago. That was a mouthful. And then we talked with Laura Webster. She serves as in the Northwest region as the vice president of ethics at Common Spirit Health. And then we talked with Jason Eberl, who is the Mater Chair in Healthcare Ethics at St. Louis University. So we interviewed them right on the floor at the display hall at ASBH. And we asked each of them, what is one important theological or ethical question that is coming up in your work in healthcare right now? So we just let them roll with that. We ask a few questions for dialogue. They're short interviews, and we'll kind of get a survey that way. So before we jump into those interviews, Dan, what were some of the highlights and takeaways that you experienced from the 2025 ASBH annual conference?
Well, yeah, Tom, there were a lot, and I'll bring in two. The first is a paper that I attended by Jamie Riches and Emily Hahn, entitled "The Malignancy of Metrics: How Hospital Rankings and Performance Metrics Undermine Cancer Care." And there's a movement in academia, but also in healthcare to get away from these rankings. That the rankings are seen as either inaccurate or unhelpful. They're not really measuring what we care about, which are outcomes, whether it's in education, positive educational outcomes, or in medicine, positive patient outcomes. And what they argue is there is really no correlation between the rankings and patient outcomes. And they gave the one example that really stuck with me is, and obviously they're talking about cancer care, it's in the title of the paper, is about a patient who discharges from the hospital to go attend a middle school graduation for a child. It's something that patients will do all the time, very normal kind of a thing, and then gets readmitted once the patient comes back to receive continued care. And this hurts the hospital's rankings because you have a quick readmission. Now, so that, does this discourage the medical team from putting that out as an option? Oh, you could leave and come back, right? I mean, so there's all these perverse incentives. Clearly, the best thing for that patient is to leave the hospital, attend the graduation or the dance recital, whatever it is, the baseball game, in return for their mental health, but also their physical health, right? That these things are correlated, as we know. And so I thought that was really interesting. And I think it speaks to something that we'll see as we go through these interviews, and that, Tom, you and I have talked about a lot, just how much structures and organizational decisions influence care. How much do we value the ranking that we have as a hospital or as a hospital system? And does that correlate at all with patient well-being, patient health? The other paper was by Juliana Friend, and this was on the need for more patient involvement in the adoption and use of AI. And she argued AI is moving very quickly, and there are people, developers, the developing community doesn't really want to slow that down. But it's also moving toward a consolidation of power. The power is being held in the hands of few, and patients are being left out of these conversations. They don't have a lot of levers to pull regarding their own care. I mean, they could decide they don't want the ambient technology to be used, but that's just one application. That's one use case. There are other use cases that they don't get to look behind the curtain to see how decisions are being made. And what she argues is basically there needs to be more diffusion of power. The power needs to be not so consolidated in the hands of the developers or the C-suite executives, but rather given down to the patients. The patients are enabled to make decisions about how AI is involved in their own care. And I think, this really calls for further conversation about how much and what kind of input patients should have on AI as it promises to transform the healthcare system over the next 5 or 10 years. And I think it speaks to, if you think about this in a Catholic framework, it speaks to the importance of participation. Catholic tradition, the social tradition, always emphasizing the importance of participation from the community when it comes to decisions like this. That if a decision is going to affect me, I ought to be able to participate in how that decision is being made. My voice should be enabled to be raised up and listened to, and especially the voices of those who are more vulnerable or marginalized. That, as we see in the work of Pope Francis, but it goes all the way back. You can see it in John Paul II. You can see it in Paul VI. That those people become protagonists in their own development and liberation and own well-being. That they're not on the sidelines. They're not passive recipients of the largesse of the powerful, but rather that they become protagonists in their own lives. So I think it was an interesting paper that made me continue to think about AI and these kind of procedural questions about who gets to be in the room, whose voice gets to be listened to. So Tom, those are two papers that I found interesting. I'm going to throw it back to you and ask you the same question. What did you see at the ASBH?
Yeah, absolutely. I wanted to actually comment on the Juliana Friend article real quick, or session that you attended, because I'm assuming she is not coming at all from the Catholic social tradition, right? Like,
No.
that's an interesting point where we can be placing that into dialogue with the tradition that we're working out of, where you mentioned I forget which principle it was now that you mentioned in relation to what was it again?
Well, participation. Yeah, just
Participation. Yeah.
yeah.
Thank you. I was thinking of also subsidiarity, rights and responsibilities, right? That we need that diffusion of power for people to be involved in their own healthcare. So, yeah, so I think that's an interesting catch. I'll also mention two that stood out to me. And just in general, I was struck, not surprised, but struck by the sheer volume of different sessions that dealt with AI in some way, shape, or form. That's obviously such a key issue. And even Jason Eberl during our interview jokes about that when we get to that. But there were two that stood out for me. So the first one was one of the plenary sessions with Dr. Jerome Adams. And the title of that was Making the Case for Health Equity, Ethical Imperatives and Practical Strategies. He had just a fascinating perspective. And just, I think we both commented afterwards, at just the sheer volume of information that he seems able to keep in his mind and organize and draw upon. He served as the Surgeon General from 2017 to 2021. So during the first Trump administration and also during the COVID pandemic. Just a fascinating perspective. He now serves as the Executive Director of Health Equity Initiatives at Indiana University. He also wrote a book called Crisis and Chaos, Lessons from the Front Lines of the War Against COVID. We'll put a link to that in the show notes. But what stood out to me was just how adamant he was about identifying himself as a medical professional, first and foremost, with a public role to play as the Surgeon General, and being nonpartisan in that role. And then from that space, advocating for health equity and advising the president and the cabinet in the way that he felt like he could do the most good. He received criticism for serving in that role from both friends and professionals. He asked an interesting question at one point. He said, every night I would ask myself, in this role, given all of its implications, the good, the bad, and the ugly, did I do more good than harm today? And do I believe that I can continue to do more good than harm in this role tomorrow? And he said, as long as I can answer yes, I knew that I could keep going through all the stress. Which to me, he didn't talk about this as discernment, but that seems like a great discernment question. Where do we focus our energies? What roles do we play? And actually, a lot of what we're talking about is setting us up nicely for our next topic on organizational ethics, where we'll talk about social roles. So that was one that I just was really just personally inspired by the way he served publicly with high integrity under a ton of pressure. And so I thought, and that was, yeah, it was inspiring. The other one that I thought was kind of interesting was a panel on psychedelic ethics. The title was Psychedelic Ethics, Learning from the Past to Inform the Future. So this was a panel made up of historians, philosophers looking at the history of psychedelics in general, but also research in particular on the effects. I think a lot of listeners will have heard some of the anecdotal headlines that are out there about psychedelic medicines being potentially useful for PTSD, depression, anxiety, those kinds of things. There was also a legal scholar and a lawyer talking about the legal implications. There was a policy discussion, and then a discussion about the clinical aspects, specifically focused on IRB standards for participant safety, for trying to do these in a way that gets us good data so we can make good decisions, but also protects the safety of participants. Again, IRB standards, for those who might not know, Institutional Review Board, which is basically every major research institute, universities, teaching hospitals. In order to do any studies on human subjects, you have to have your all of your protocols like very scrutinized to ensure that you are protecting the safety of participants in any kind of clinical trial. So that was fascinating because I think it's something that we're wrestling with in our culture. Interesting to note that not every psychedelic medicine that they were talking about is equal. Ketamine, for example, has been now approved by the FDA for depression. But once things are approved, then clinicians can start prescribing for off-label uses. So it's like, what are the implications of that? And then they talked about things like psilocybin, MDMA, more commonly or more colloquial maybe called Molly. But just it really showed me that the state of the field legally and from a research perspective is really coming together and not well consolidated. And then just a last thought, as these things become potentially more researched and have actual treatment protocols and, if they make it into the DSM or something like that in the future, we might see some of these starting to come up in our Catholic facilities where clinicians are providing or wanting to prescribe and do therapies with some of these. So no big takeaways right now, other than to say it's something to keep our eye on as it develops as we go along.
Yeah. And the little research I've done on this is that there isn't a lot out there from the Catholic side on these psychedelics. And so there's going to need to be, I think you're right. I think there's a movement afoot, and because there are benefits that have been demonstrated. So I think we're going to need to have more reflection on these. Yeah, fascinating session. Thanks, Tom. So now, why don't we now turn to the interviews, which I'll note are audio only. So you're not going to see the interviews, but you will hear them. So we'll turn now to our three interview subjects.
Okay.
So we're here on the exhibit hall of the ASBH in Portland, Oregon, and we have our first guest, Michael McCarthy. Michael, can you introduce yourself?
My name is Michael McCarthy. I'm the Graduate Program Director for the Healthcare Mission Leadership Program at Loyola University Chicago and the Neiswanger Institute for Bioethics.
And what we're going to do today is ask people the same question. Michael, and the question is this: what is one important issue that you are facing today in healthcare ethics? So take that in any direction you'd like.
All right. No, I think one of the main issues, and it's really a combination of multiple issues, is that we see the inequalities in our society. They end up in our health systems. And I would say a tangible example is the issue that we're facing of migration, and that Loyola has a detention center that is a mile and a half from the health system. And so when there are health issues at the detention center, which have only increased with the number of people that have been detained, the migrants come with ICE to Loyola. And so we can talk about the political reality and the challenges of migration, but in healthcare, that doesn't matter. That when people show up at our doors, and with the commitment of Catholic healthcare to care for poor, marginalized, and vulnerable populations, poor, marginalized, and vulnerable populations are a part of the social inequalities that exist in our society. And we know those social inequalities have health consequences. The other challenge is that those health consequences, once we can stabilize, treat, where do we discharge them? Or we discharge them back into the same environment in which those inequalities exist, or those challenges exist. And so there is a challenge in healthcare of, one, triaging and taking care of the patients who are poor and vulnerable, but how are we attentive to addressing some of those social inequalities in society? Because those are going to continue to have consequences. So I would say the work that Sister Mary has been doing on Capitol Hill is important work, because when we take away the little funding and little resources and underinsured persons, that's going to create greater challenges, not only for healthcare more broadly, but if you're a healthcare organization committed to care for poor and vulnerable, when the number of poor and vulnerable increase, that's going to affect how we're able to care and what we're able to do for our patient population.
Are you noticing with increased numbers of people in these detention centers, I could see almost like a public health increase in risk? Like, are you noticing that there's more or more severe type cases coming in because of if these are more densely populated now?
Yeah, not yet. I would say not yet, and not in the way in which we saw this the last time this happened, which was around COVID, right? That there was spread through prisons, but also detention centers of COVID very early on because of the number of people that were kept in closed quarters. So again, it's not to make a political commentary, but it is just to say that choices we make in society have real impact, and that impact is going to affect the way in which we deliver care, where we care for our patients. And as we care for those who need the most care, the environment that they go back into is critically important. I mean, we could apply that, we could think about other issues that also that impacts, but I think of our complex cases when we're having trouble discharging a patient, it's not because they have, a family or a home or insurance that's going to cover. It's the people that don't have insurance or don't have a family, don't have safe living conditions that create a lot of the clinical ethics challenges around discharging patients to a safe environment that continue to just perpetuate in our health systems.
It's like an acute example of how social determinants of health translate directly into acute health problems that then compound and become hard to manage. Yeah.
So one of the, what I'm curious about is, have you had ethics consults related to ICE bringing people in from detention centers? What are the moral challenges that you've seen? I mean, this is relatively new, right? That you're having this, especially at scale, that you're seeing it at this kind of scale. Are there moral challenges that you're encountering in that direction?
I think in some sense we can break it down into, it's again not the challenge of ICE necessarily bringing patients, but I think when we have patients that are brought in that are detained, that how do we think about, and I think this is an open question, how do we think about how we prioritize the need to care for that patient? because when they come into the health system, they're a patient first. And so how do we both respect the rule of law, but also make sure that we're giving the patient the health attention that they need and able to treat them in a way that makes them safe so that they're able for discharge. So in some sense, what we're doing is not changing, but I think our mentality and the way in which we think about it is changed when someone comes in detained with, a law enforcement officer. And so I think thinking about how do we prioritize, just as we do with every person, every patient that comes in, seeing that patient, caring for that patient as the priority.
Are there any learnings from their takeaways that you've instituted for, because it's sort of like a heightened vulnerability that you're dealing with a patient in that kind of context. Like, have you come up with creative solutions or ways to approach that as a care team or as a larger ministry?
Yeah, so I think Mark Kaszewski is kind of a leader in thinking around the intersection of immigration and bioethics. So he's the director of the Neiswanger Institute. And one of the things that I think would benefit is everyone looking at your forensic patient policy, right? When you bring in someone who is detained, what is your policy? Like, are we prioritizing the patient? And how are we balancing keeping our healthcare team and our healthcare workers safe, protected, but also making sure that the patient is getting what they need? And I think those are probably not policies that we look at with great regularity. But I think this heightened kind of, especially in Chicago, around detaining persons and detaining people who will come in as patients, looking at what those policies are and how can you best address that collaboratively within your team to see what's our policy. Is it prioritizing the patient, and is it a policy that keeps our team safe? Both of those have to be kind of kept in tension.
Yeah, I would not have thought of that, but you're right. That's an important policy to review. Yeah.
Well, Michael, thank you so much for your time and your insights on this really important topic. It's certainly timely, and we're appreciative, as is our listening audience. So thanks.
Yeah, no, thank
Come
you.
by the booth.
Yeah, thanks.
Okay, we are still here on the floor at ASBH, and we are with Laura Webster. So, want to introduce yourself and where you're coming from?
Yeah, good morning. I'm Laura Webster. I am from Seattle, Washington. I am the Region Vice President for Common Spirit Health in the Northwest, so I oversee the Washington and Oregon markets. I'm also a registered nurse by trade.
Oh, cool. Regional Vice President specifically for ethics, or do you also do mission just ethics?
Just ethics.
Okay, great. Just want to clarify for
Yeah.
folks at home. Yeah. Okay, well, we're asking everybody this question. What is one issue that you see coming up in your work that you think would benefit from more reflection, or that you're thinking about noodling with your team?
Yeah, I really appreciate this question. I think the biggest issue maybe in healthcare and in our communities is our inability to have conversations. And so being able to sit down and actually listen, not to respond, but to be present with and to understand. And I think the more that we can do that, both from a bedside level to a community health level to an organizational level, the more we can understand and fulfill the mission of serving our community and helping those in need. And I think that bridge between our ability to have compassion and kindness and embrace our integrity can be met by our actually being present and listening to the people that are struggling.
Wow, cool. So are there examples where you've seen that play out, or ways that you try to integrate that into how you approach ethics within Common Spirit in your ministry area?
Yeah, so I'm going to shamelessly just say that my colleagues that I get to work with are phenomenal. So Beckett Grummel's has an article out about the concept of not saying no mission, no margin. So a lot of our resource and intense conversations where we don't have the margin to fulfill this mission, and actually going into a place where we say our budget statement is a moral document, and we can have mission and margin. And putting that "and" statement in is also something that Leslie Kuhnel, one of the other VPs I get to work with, talks about all the time. And I think that "and" is what helps us actually also communicate. But I think there's a lot of different ways it could play out organizationally. What comes to mind are these conversations about the limitations in healthcare.
Do you have, are there specific practices, that you've instituted a common spirit for listening? You said the most important thing is to have kind of a spirit of listening. How do you go about that? How do you operationalize that, whether it's in an ethics committee meeting or in a meeting with a family? Are there specific practices that you use?
Yeah, that's a great question. So I'll say on an organizational level, we have discernment, which is not unfamiliar to the tradition, but that is something that all of our leaders are aware of and embrace. They involve the ethics team and others that are educated in discernment practices to really think through, are we becoming who we want to be, right? Are we actually grounded in our mission, vision, and values? At the bedside, our clinical ethics responders and clinical ethicists have support and training, and not only having the time to be with people, because I think that's one of the limitations. We feel so pressured to go from point A to point B, and we have an objective, right? Like, I'm going to go and do this consult. And I think if you take actually more of a phenomenology type approach to go in and say, there's this phenomenon that's occurring, and I want to understand what's important to you. Can you help me hear what's important to you at this moment? And starting off with that introduction as an ethics responder or a clinical ethicist actually allows the patient or family to take us where they want to go, and then giving them that time to actually sit and listen.
Yeah, I feel like sometimes if that step is skipped, you get to some of those end of life discussions, and then can be this tension between the care team and what the family wants, and then that's when the ethics committee gets the call, right? So you can almost forestall that. What I hear you saying, by bringing in listening and discernment all throughout the process and not at the very end.
Yeah, I mean, it would be great. I think oftentimes people hear things and they make the assumption. So one of the classic things is, I want everything to be done for my loved one. As an ethicist, I know everything is a really common word. And they might want everything that alleviates the suffering of their loved one, even if it shortens the time that they have with us. They might want everything that's medically reasonable that will help to keep them in a state that is acceptable to them. And we don't actually ask those nuanced questions, but if we start asking things like, tell me more, or help me understand what everything looks like to you, or I'm really interested in what your loved one would say if they were here, and tell me how that's grounded in who they are, right? Those questions that really go further from that position statement, what you want to do, into the interest. And so I think part of listening is getting to that interest part for anybody, whether it's the executive that you're talking to, for the CEO, for the budget, for the CFO, or the patient and family member that are trying to navigate end of life conversations, or should we discharge home when they're unsafe and falling.
Yeah, I'm hearing a connection between maybe things that might be discussed in like a formation program, like about here's what discernment is, here's how you do it, right? Then having an overlap into how ethics consults might go more smoothly.
Yeah, absolutely. I mean, we partner with Mission Information, and I think every event that you have in your life, right, is formative to some degree.
Yeah.
So it definitely extends in making sure that people are aware of how they're influenced.
Awesome. Well, thank you so much for stopping by and chatting with us and sharing your insights. Great to have you here.
Yeah, thanks for snagging me at ASBH.
Yeah, good luck in your ministry and your work.
Thank you so much.
Thank you. Okay, we're coming back again from the floor at ASBH. We are standing 10 feet from a live llama, the No Drama Llama, helping us to relax. I guess ethicists need, a little extra relaxation. But we're here with Jason Eberl, and you want to introduce yourself and to the people at home?
Yeah, hi. So I'm Jason, and I direct the Albert Carnegie Center for Bioethics at St. Louis University.
Great. So we're asking everybody the same question. What's one issue that you think is important that needs some good attention in healthcare, Catholic healthcare right now?
Can I give an answer that's not AI? Because
Please do. I mean, we're all sick of hearing about it from Dan.
exactly. But no, I mean, AI obviously is one of the most important things. But, I think obviously ever since COVID, right, public health, global health, bioethics as a whole, not just Catholic bioethics, it was kind of a neglected area. And I think, the next pandemic will come, and probably sooner than we expect. So I think focusing on public health ethics, especially preventive measures that can be put in place so we can manage the public health, issues better than we did last time.
Do you have like any specific, are you thinking vaccinations? Are you thinking, attention to the social drivers of health? Do you have any specifics that kind of in that public health space that
Yeah,
are important?
I would say, like, in terms of the thing we can work on right now would be social determinants of health, which I'm a big fan of Daniel Dawes's book, The Political Determinants of Health, because what we call the social determinants are often determined by political decisions. So that's stuff we need to focus on right now, in all aspects of healthcare. And then, I think also educating people about vaccines. I mean, the polarized animus around vaccines and vaccine mandates, even despite what I took to be somewhat clear moral guidance from the church, from Pope Francis, yet a lot of Catholics, particularly in the U.S., very polarized on this. And so I think just more education in that area, not about the science as well as about the morality, is something we can start doing now, sort of laying the track.
Are there any efforts in that realm that you guys are working on at the Nagy Center, or?
Not on that specific realm. I mean, I've done some op-eds and public outreach stuff, mostly at the height of the pandemic related to that. Our focus on our center, and this would maybe be another answer if I can get two, is disability. Our center really has a strong focus on disability bioethics and that perspective. And I think for me personally, I'm seeing a lot of resurgence of what we used to call eugenics and eugenic mindset in our culture. And so I think as Catholics, especially who are concerned, the preferential option for the poor and vulnerable, that obviously includes people who are being marginalized, being disenfranchised because they have a disability, intellectual or physical.
And who are you reading when you think about disability ethics? Are there authors or who you think really are doing a good job in this area right now?
Yeah. So sort of a classic, it was sort of just wants a starting point into this. Rosemary Garland Thompson from Emory University. She's retired now, but she wrote this classic book called Freakery. And it was all about the history of freak shows back in the Barnum and Bailey and all that stuff. And again, the social attitudes about freakery back then, fast forward to now, and we have like My 600-Pound Life and Lives of Little People and so on. So there's all sorts of ways in which you might think that these are harmless things or these people are choosing to be on TV and so on. But we kind of do create this otherness, this othering, this freak show mentality. In the specifically Catholic realm, I'll plug a couple of my own colleagues, actually, Harold Broswell. He's doing a lot of work on how disability discrimination impacts specifically end-of-life care and some of the stuff we're seeing in Canada related to medical aid in dying. And then Miguel Romero, who's a disability theologian, and he's also trained in liberation theology and really brings a really well-informed, grounded, theoretical, Thomistic, and Thomist perspective on all these issues. And finally, I'll also mention a graduate of our program who's really become a up-and-coming big name in this area, Devin Stahl at Baylor University. She has a new book on bioenhancement and the vulnerable body, and she's also finishing up a book on the history of various Christian attitudes about disability throughout history. Wow.
So when you use that phrase eugenics, is it more in terms of, say, denying certain forms of care or treatment that would lead to higher mortality rates versus sort of, engineering in the womb where you're trying to, or is it both?
It's both, and I think it's a combination of three things. I think it's one, how we care for the vulnerable who are dying, whether they're dying from a chronic disability or not. There was a case during COVID, you may recall Michael Hickson. He was a quadriplegic African-American man in Texas who the doctors discontinued life-sustaining treatment over his family's objection. And his wife actually recorded and took to the press, this is on NPR covered this, the doctor literally saying, we don't see him having any quality of life, right? And so I think there's that one form of discrimination. Two, the social services we provide on a daily basis for people with disabilities, and especially as we're seeing all the cuts in the current administration. But it's not just this current administration, it's been endemic. We have the American Disabilities Act since 1990, yet I have friends who have children with behavioral disorders who are having a huge time getting both public and even private Christian schools or Catholic schools to provide the bare minimum of services that they're legally required to provide, but they find ways to get around that. And then going back to what I said, in the wound, right? There's a lot about gene editing, CRISPR-Cas9 and other things. The church has provided some interesting guidelines on that because the church is not opposed to gene therapy and doing some interventions, even prenatally, as long as we're not otherwise disrupting the unitive and procreative dimensions of the conjugal act in order to cure diseases, right? Provide therapeutic things. But then how you define a disease, right? Is Down syndrome a disease or just a different way of being human, right? That's a debate and discussion that we ought to be having. And the disability community, disability scholars have interesting and not monolithic perspectives on that.
So when it comes to disability, you're a philosopher, you've done a lot of theoretical work, a lot of really deep theoretical work. Where are the resources within philosophy or theology? What are the resources when you think about the disabled population and how they're treated or mistreated, as you're rightly noting? What resources are you drawing on when you're thinking about these communities?
I would say two main ones for me. So as I said, I'm a Thomist, so I do go back to Aquinas. That's somewhat dangerous territory because if you sort of the classic way in which Aquinas' theory of human nature and natural law is interpreted, even today, is we could say is probably not very disability friendly.
Yeah.
I wouldn't, maybe even outright ableist in certain ways. But again, I go back to my colleague Miguel Romero, who has found, we do a really deep dive into some of these texts and sort of examine. So he and I co-authored a paper on the tree of life in the Garden of Eden, and just that concept. Again, as Catholics, we're not taking the story literally, but looking at this concept, the idea that humans in our pre-fallen state weren't it's not like we necessarily had healthy bodies, and we had to eat of the tree of life to avoid death. Death is a natural condition of being human. It's not just a result of the fall. And so when we think about vulnerability and disease and disability, this is not simply, as we often think of it, the effects of sin, right? It is actually something where we got to reflect on why did God create us this way in order to have these vulnerabilities and finding value in those vulnerabilities. Another theologian I'll mention who's really good on this at Notre Dame is Gerald McKinney. He's got a book. He's got several books, but one's called "To Relieve the Human Condition." So his work on the nature of vulnerability and the value of acknowledging our vulnerability. Pope Francis talks about this, and the dicastery for the Doctrine of the Faith and Samaritanus Bonus, for example.
Yeah, I think that the issue of vulnerability I think is so interesting, and I think in the AI, to bring it back to AI, it took me all of 4 minutes. It's not like yeah. I think what's interesting is that a lot of people are turning to AI to avoid being vulnerable. Whether it's, that we can use AI for therapy or for friendship or for romantic partnership, because it's painful to be in relationship with others. It's painful to put yourself out there. And I think you're absolutely right. I think vulnerability is one of the most important theological concepts. It is part of the human condition. And it's also, it opens us up to others, right? It's actually to be able to be wounded, which is the literal meaning of what vulnerability is the beginning of our relationships with others and God. Yep. Right? It's without that, we're less apt to be open to God's grace, less apt to be open to the graces that others provide us. And so I think it's that's a really important resource to draw upon.
Yeah, a couple quick thoughts that inspired. So again, another thinker, another resource for me, and I think a very accessible book. Alistair McIntyre, who just recently passed away, well-known philosopher at Notre Dame. His book called Dependent Rational Animals, right? Where he talks about this need to acknowledge the virtues of acknowledged dependency. I cite that book all over the place in my writings. And then the other thought, going back to AI, Pope Francis talks about the culture of encounter. And we really do need to kind of bring, we all flew here, for ASBH. I actually flew 10 hours from overseas to come here. Why? Because we want to be talking to each other. We could have done this over Zoom, but there's value to being 10 feet from a llama, right? Just having that experience.
Clearly, there's value. Look at how relaxed we are.
Exactly. Yeah. So yeah. I mean, and then again, approaching the vulnerable. Someone was commenting about actually, I think it was one of you guys last night at dinner. Was commenting about in Portland. We're in Portland, Oregon, and there's a lot of homeless people around, but a lot of them are very friendly, and they just they'll say hi to you, and they just want you to say hi back sometimes. I mean, yes, of course, if you have some money or can help them out, they want that as well. But it's not like the aggressive panhandling or just the, give me money. They just want to be recognized as people, right? And even if you say, like, I hardly ever carry cash on me, so I'm just always like, I'm sorry I had no cash. I'm at least acknowledging them, that's, and their needs. Yeah.
Just a final thought that when you were talking about the dependent piece and vulnerability, I think in our culture, we fluctuate between like radical independence, it's just me, or the autonomy value or principle. And then there's a lot of talk now about codependence, like, oh, you can't be overly. But there's this middle ground of like interdependence. And we don't really have much of a language for talking about that or implementing it in community. And I guess ASBH and Catholic healthcare are hopefully places where we can embody some of that.
Yeah. And I think, so interesting, because ASBH, right? So, we're Catholic healthcare within the largely secular bioethics realm, where the old joke is that there are 4 principles: autonomy, autonomy, autonomy. Oh, don't forget autonomy. Yeah. But as actually, it's kind of an old joke, because when I say at ASBH, a lot of the presentations I go to, the work I know our students are doing at St. Louis University, is very much focused on second personal relations, fostering that culture of encounter, even if we don't use that language, right? Addressing vulnerabilities, addressing structural inequalities, and really trying to celebrate differences. Where, again, some people have the impression that ASBH and bioethics in general in the U.S. is very secularized. In some ways, it is, but in other ways, it's also a place where Catholic bioethics can be present. And we have a bioethics and Christian theology affinity group. And I was out working luncheon earlier on integrating theology and religious discourse into teaching, right? So, it's not all over the place, but there is a desire for there to be these differing perspectives. There's not like one monolithic moral tradition that's being touted here.
Well, Jason, thank you so much for your time and for your insight. We appreciate it.
Yeah, thanks for the invitation.
Thanks for stopping by.
Glad you guys are here.
Yeah. Well, that was a lot of fun. I know you and I both enjoyed being able to talk with people live, not just the interviews, but really all the people that we connected with at ASBH. We felt like it was really fruitful for us as a center. Great connections for being part of the discourse. So as we kind of wrap up, Dan, what are some of the impressions you're left with or takeaways as we reflect on the state of the field?
So, Tom, I have 3. The first is that, when I think about these 3 interviews, and even a lot of the conversations that we had at the ASBH, there's a strong social focus. Both McCarthy and Eberl talk about the social drivers or determinants of health, public health, really getting at how social conditions, those surrounding social conditions that have nothing directly to do with healthcare, how those social conditions produce ethical dilemmas or resolve them, right? So if you have structures that promote human well-being, right, we have fewer of those kind of moral dilemmas. But when we have structures that are broken, that don't promote the well-being of all people, it creates new dilemmas within the healthcare system, new problems. And so, I mean, this is, the first point is really that there's a focus here on the social structures. And again, I would say, we're going to take this up in our December podcast. So be on the lookout for that. The second point is, so we've got this kind of social focus, first of all. Laura Webster and Jason Eberl bring us to this kind of human-centered focus. Laura bringing us to communication. I thought that her insight into communication and practices of communication, where, she asks, what do you mean by quote unquote everything? If a family, right, when she says the family wants everything done, well, what do you mean? Tell me more about that. I thought that was really interesting, because we tend to read in to the things that people communicate to us. We read in our own understandings. And what Laura is asking us to do in our work in ethics is to not read in, but rather to draw out from them what they really think everything means, because they may not know what is possible in this setting, in this highly technological, medicalized setting. They might not know what's beneficial or what's medically indicated, right? So I think that was a really fascinating question that Laura brought to us. And then with Jason, looking at disability and vulnerability, this core aspect of what it means to be human. We are dependent rational animals, as he cites Alasdair MacIntyre. We are vulnerable creatures. And so bringing us to this kind of really human-centered focus in ethics, which leads to my third and final point, is that these are not clinical issues. What they didn't do is bring in a clinical case. So, what we really need to be talking about is NRP, which I think we do need to be talking about. I'm not saying that's not something, but they're saying that if we ask them about one issue, which is all we did, they brought us this kind of social and human-centered issues, these social and human-centered issues that we need to address. So I found that fascinating. And I think there's a profound shift that's happened over the last 20 years. When the ASBH started in 1998, it would be interesting to go back and see what the program was. I wonder if you had as much of a focus on this kind of the structural, social, and human aspects of healthcare. My hunch is that it was more clinically focused on these kind of edge cases, these difficult cases, these moral dilemmas. So I think we have seen a shift, and it's, I think, borne out in the interviews that we just listened to.
Yeah. I mean, I don't feel like I'm just repeating myself, but I guess all podcasters do have their themes, right? Catholic social teaching has a lot to say even at the clinical level. And of course, as you know, I have a strong interest in sort of the integration of spiritual and contemplative practices into decision making and discernment, whether that's clinical or from a leadership perspective. And I do think that Laura's comments about listening first, most contemplative practices begin with silence and listening, right? And listening for the experience. You had that great question of, what do you want? What's at stake for you before I get into what's at stake for me as the clinician or the ethicist, right? So yeah, really powerful stuff. I had, I guess, two takeaways, and then just a comment for listeners who might want to follow up on some of these things that have been brought up in this podcast, because it's been so wide ranging. I similarly really noticed that the social dimension of these cases was front and center, at least in our interviews, but even if just looking over the program for ASBH, of course there were, clinical traditional bioethics cases, but there's a lot of sessions about health equity and questions about justice and who has access and those kinds of things. And I think one of the edges that I was pushed in listening to people was, it's important that we're talking about social determinants. And there's a way in which, if we're going to ask those questions, we have to be willing to move into the space of politics and policy. And I use that with a small p. I don't mean that in terms of partisan politics of the current two-party system, but rather to say that the laws we have on the books, the practices that we have, the people we elect, they shape those social determinants in really profound ways. So again, it's not being partisan, and you and I are very committed to doing this in a way that is not culture wars, but bringing people into a dialogue. But it's going to require all sectors of society to go, again, to the political broadly understood, not just politics, but the polis, that the people that make up our community. The things that we are needing to solve on the social level, even in Catholic healthcare, one system or ministry alone can't solve these bigger problems. Even Catholic healthcare as a whole can't solve that without working with the government at different levels, and other other providers and practitioners. So that was one takeaway for me. The other one was just how uncanny it was that we planned out the fact that our next session, our next topic was going to be on organizational ethics before having these conversations, and just how much the discussion, because it's focused on that social level, led into questions about structures and culture and the roles that we play as leaders in this field, whether we're ethicists, mission leaders, administrators, executives, patients. We all have a role to play, and we all engage with the structure and the culture of healthcare in America, such as it is today, or Catholic healthcare specifically. So that's a teaser that I think next topic is actually going to provide some more meat and potatoes and flesh to that conversation in a really helpful way. And then the last one, oh, did you want to jump in? Go ahead.
No, please.
Okay, you look like you were about to say something. The last one I'll mention is just more of a practical piece for people watching or listening. There were several different authors or specific books or thinkers that were mentioned in those interviews, and we've collated links to each of those. So in many cases, it's to like their faculty page, or if they have a professional web page, or to particular books. So if any of those caught your attention, check the show notes for a link to any of those resources. Any last thoughts, Dan, before we sign off?
Yeah, I just think your point about organizational ethics, we've seen this in so many of the podcasts we've done, but the other work we've done, there really is a deep need for this. And so we're excited to record the next one too. I think these will, as you noted, this one leads into the next one on organizational ethics, because I think, there's a lot of power in consolidated in the higher level aspects of an organization, not just at the bedside, physicians and nurses. And so the question is, how do we evaluate that? How do we provide guidance in those ways? Because I think whether you're talking about organizational ethics or the broader social structures in the polis, as you noted, both of those have an enormous amount of influence on what care this patient gets who's in front of you. I think we'll dive in and take a look, and I think we'll see resonances that if we go back and listen to some of these podcasts, that we've already discussed this to a large degree, but to be able to dedicate our time to that in our next podcast, I think will be time well spent.
Absolutely. Yeah. Well, thanks, Dan, and thanks to all of you for listening or watching. And for Dan Daly, I'm Tom Bushlack, and this has been Ethics on Call. As always, you can find our podcast on YouTube, Spotify, Apple, or our website, which is theologyandethics.org/podcast, theologyandethics.org/podcast. I will note as well on our website, if you want to drop us a note or ask us a question, there's a contact form. And there is now a place to sign up to receive our newsletter. So if you click on newsletter, there is a form where you can put in your email. You can always opt out later if you want to, but I'll throw that out there. And if you're listening or watching on any of the podcast platforms, as always, we ask that you follow or subscribe, as well as leave us a 5-star review. And then written comments also are really helpful for people to learn more about the show and to get it promoted on those platforms. So thanks again for listening. Hope to talk to you soon, and see you next time.